So thank you very much to Julio Montaner and the conference organizers for the invitation to speak here on behalf of MSF, Doctors Without Borders. The title of this presentation is Integrating Treatment as Prevention into HIV/TB Programs, because from the perspective of MSF, that's the question that we need to ask ourselves. As you can see from this slide, MSF has HIV programs in 23 countries, supports HIV programs in most of these countries, and they're mostly in sub-Saharan Africa and Asia, and they're mostly high prevalence contexts. And so we do need to address that question, should we, and how to integrate treatment as prevention perspective into our activities. So I'll briefly outline the MSF approach to treatment as prevention, and then looking at a case study looking at Swaziland, where we have a fairly well-developed treatment as prevention program, looking at Swaziland to see what sorts of lessons, clinical, HR, logistic, we can learn from our experience there. I think this is probably the image of MSF's activity that is more familiar. It's working in unstable settings, in conflict settings, which tend to be low access, low coverage. And in these settings, we focus on increasing access to HIV testing, care and treatment. We also focus on quality of care through adherence support and viral load monitoring, but probably this is secondary to focusing on access. And in these settings, PMTCT, B and B+ may be systematically considered, but we would say that treatment as prevention is not an explicit priority in these settings where we're focusing on coverage, first of all. But then if we take an example of a country at the other end of the spectrum, again, Swaziland, this is a country that has achieved high access, good ARC coverage, and here we would be focusing treatment as prevention would be much more of an explicit priority. And what we mean by that is focusing on quality of care, on cascade optimization, on making sure there is maximal linkage to care, good treatment support, routine viral load monitoring, obviously for showing effective treatment response, and also reaching neglected populations. And by optimizing the HIV treatment cascade, obviously we would hope to be reducing community viral load and hence transmission. And then in certain high coverage contexts, we would actually go further in terms of accelerating access to ART, accelerated ART, so PMTCT+, but also universal adult ART. And in these contexts, we would be doing this, we would be implementing or supporting implementation of these interventions as operational research, because the idea would be to learn lessons from these settings that could inform national policy, could be relevant in other settings. So if we look at Swaziland, as mentioned, it is a high prevalence context, 31% in the adult population, according to the SHIM study. That area in pink there, where you can see the A, that is Shiselweni. It's one region in the country which is supported by MSF since 2007, at a time when access to care was poorer. And as I said, the Ministry of Health has successfully increased access to care, such that ART coverage is now around 85% in adults, a very impressive ART coverage. It's lower in children. The 12-month retention in care is acceptable at 80%. What we see is the HIV testing rates lag a bit behind expectations. For a population of 210,000 and a prevalence of 31%, we would hope to have more than 40,000 HIV tests per year. And so if we look at the MSF treatment as prevention program in Shiselweni, here we see the HIV cascade, which we're all familiar with. We would look at the treatment as prevention program as the whole package of activities that optimize that focus on cascade optimization and accelerated ART. So as I mentioned, testing rates are lower than we would hope, and one intervention would be intensified community testing and linkage to care. For improving retention in care, we would be looking at treatment clubs, community-based ART delivery. We talked about implementing routine viral load monitoring. This did not exist until quite recently in Swaziland. And of course, enhanced adherence counselling for people with detectable viral load. And then we mentioned accelerated ART. These would be PMTCT+ and early access to ART for all adults pilot studies. All of this would be supported by surveillance, both to look at the unintended consequences of early access to ART, such as resistance, but also to look at the expected positive outcomes, TB surveillance, early infant diagnosis surveillance, and incidence modelling. This has been supported by a 1.5-year ethnographic study and is being carried out. All of these activities are carried out in collaboration with the Swaziland National AIDS Programme. And I think an important point, as I have mentioned, is that you'll see the word evaluation throughout this slide. This is being done as implementation research. So each of these activities is being stringently evaluated. So now just to look at a couple of examples from of lessons learned from this early experience since 2012. As mentioned, testing rates are not yet optimal in Shiselweni. 50% of people know their status, and also testing is skewed heavily towards women as a result of a very effective ANC program. So for us, the question was not only could community HTC increase rates of testing in Swaziland, but also could increase rates of testing amongst men with acceptable rates of linkage to care. So two models have been evaluated: a mobile comprehensive testing model, which involves testing at major events or sites chosen with community leaders, and a home-based HTC approach. And if we look at those two models, we see they actually reach quite a different population. This door-to-door campaign, this is based on 7,000 home-based tests, and we see that it reaches actually a very young population. There were quite a few, out of 3,000 people tested, 3,000 young people tested, there were 60 or 70 positive, which may not be a very high positivity rate, but it's still a significant group of people that could have been potentially missed from the PMTCT program. And then if we look at other mobile strategies, we see they reach an older and working population, so quite a different demographic. In terms of coverage, in terms of male testing, mobile testing, major events reached quite a good proportion of men, but also to the right there, the door-to-door campaign reached 40% of people tested were men. So this also shows potential to increase testing amongst men. In terms of cost, door-to-door testing looks comparatively cost efficient there at $11 per test, mobile events at nearly $24 per test. But confirmed linkage to care, to pre-ART care at 1 month was just 30%. And of course, that's a very stringent definition of linkage to care, but I think what we had to conclude from this early experience is that intensified community testing in Swaziland so far has been a good way to reach men and possibly children missed from the PMTCT program, but may not be cost effective until we establish ways of improving linkage to care. And in 2014, we're looking at 3 strategies that have been tested in other contexts, but not to my knowledge in Swaziland: individual case management, point of care eligibility determination by PIMA, and a buddy strategy. Now, maybe moving on to routine viral load monitoring. Again, a few lessons to learn here, which I think are relevant to treatment as prevention. In Shiselweni, we've introduced routine viral load monitoring on a pilot basis using the Biocentric platform, which is a generic platform to bring down costs. And the implementation study here was really to try to develop appropriate clinical and logistic procedures to inform national rollout. Now that complicated slide is the viral load monitoring cascade, and now this was based on a sample of 3,400 viral load tests. And I just want to draw attention to 1 or 2 points here. That represented 84% coverage of the ARC cohort over 12 months, so it was a good coverage, but it was lower in children, which we think is due to the challenges of pediatric phlebotomy. Then 83% of the ART cohort, people in ART for more than 6 months, showed virological suppression. But when we looked down the cascade, we followed up 288 patients with a detectable viral load, and we saw that a significant proportion did not get any counselling. 27% did not receive any counselling. And then, of course, according to the WHO protocol, the people need to be retested. And 25% never had a follow-up test. So those are patients we've identified as high risk that are not getting a follow-up test. At the end of the slide there, you can see that 39% had virological failure on the second test, 61% resuppressed. When we look at that group with virologic failure, only 14% actually were changed to second line, which represents 1.2 switches per patient year. So that's quite a surprisingly low proportion changed to second line. 53%, so just over half, were re-referred for counselling, and the majority of these did actually resuppress. And 30% were lost, were not seen by a doctor or lost to follow-up, so representing another significant leak. So our conclusions from this early experience of implementing routine viral load monitoring are that, yes, we could achieve a relatively robust monitoring cascade in a very decentralized healthcare setting, but strong clinical supervision would be needed as we come to national rollout to reduce these leaks in the cascade. And of course, very few of the patients with virologic failure actually change to second line, and we have to ask, is this a question of clinician confidence with second line switch? Is it therefore a training need? Or was it more of a question that these were ongoing adherence problems, that the clinician was correct in identifying ongoing adherence problems? And the fact that nearly 2/3 of those people that were not changed did subsequently resuppress suggests that that is maybe the case, and we probably need to look in more detail at our adherence intervention, at or the adherence package, to make sure this is actually meeting the needs of the full range of patients that have detectable viral load. And we have operational research underway to look at that, as well as looking at the proportion of patients with virological failure who actually have resistance. And then finally, to come on to the accelerated ARC pilot studies. As we mentioned, so in Swaziland, we have already started the PMTCTP Plus pilot study last year. This year, that will be extended to all adults with HIV. These pilots aim to address questions to enable decision-making and to guide implementation. So how do we achieve good rates of initiation, retention and care adherence at all levels of CD4, both the patients who've traditionally been eligible and also patients with very high CD4s? What are the attitudes and experience of both the patients and the health workers, and how does this influence those outcomes? And what additional resources are required? What will it cost? So this is really looking at the how to implement. This implementation research is designed to complement the results of ongoing large studies, such as the ANRS study and POPART. And I won't go into this in detail. There's 1 or 2 slides about the PMTCT. There is actually a poster about this, but just to make 1 or 2 points, that although initiation rates are increasing over time since the implementation of B+, we continue to see that difference between the group with CD4 below 350 and above 350. At all time points, initiation rates were lower in the above 350 group. And there's marked variability between clinics. Now this slide, the orange bars represent the early implementation period, and the blue bars represent the late implementation period. What I wanted to point out here is that some clinics in this pilot zone achieved 100% initiation. So they initiated all eligible patients, all pregnant women who are HIV positive on combined ART, whereas in that second period, some clinics initiated less than 50%, one clinic even initiated no patients. So in some cases, we saw that this was a question of lack of staffing, but in some cases, it's actually a choice by clinics. And so what we've concluded from the pilot to this until this point is that we do see increasing initiation rates as more clinics adopt the model of care, but probably the main barriers to initiation seem to be health service related, and particularly number of staff trained to initiate. And as I said, initiation rates are lower in that CD4 over 350 group, and we have ongoing qualitative research to look at whether this is a question of attitudes, staff attitudes, patient attitudes, or training, or, as was discussed this morning, is this just a time to adaptation to a new message that completely reverses the message that we've been given for years, which is that if your CD4 count is high, you do not need to start ART. So, to sum up, what are some of the lessons that we have learnt from these pilots that have been conducted until now? Of course, the clinical lessons we've already discussed. I think these implementation studies are helping us to optimize SOPs, especially in the case of PMTCP+. They show us where to strengthen supervision, and they show us where the training needs are. In terms of HR, we can see, and this is probably not a surprise, that higher ART initiation rates occurred in facilities with more trained staff. HR is important also for enhanced adherence support. This is a relatively new intervention. The pilot involves lay health workers providing that enhanced adherence support, and the operational research will hopefully help us to identify whether this is the right approach and what types of intervention are most effective. And as mentioned, phlebotomy capacity, especially when we're talking about routine viral load monitoring, this is an important consideration for national implementation. In terms of logistics, I think there are, again, several lessons that we can learn from this implementation research. Transport for community activities, for community testing, and also for community ART delivery, which we'll be hopefully carrying out in the near future, is expensive. It represents an investment for the Ministry of Health, and I think that we need to work on producing cost-effectiveness data to help to encourage Ministry of Health, to support the Ministry of Health to actually take the risk of investing in transport infrastructure. Maybe to skip just to the bottom point there, viral load monitoring, of course, requires whole blood sampling on the whole, at least in our current program. We have, and whole blood sampling requires daily pickup. We have actually, because Swaziland has quite a good cold chain, we have implemented on-site centrifuging and refrigeration, then weekly transport. And I noticed that that's not actually one of the recommended approaches in the WHO update, but it seems to be working well in Shiselweni for now. So it means that there's just a weekly pickup or twice weekly pickup, but patients can come and have their viral load tested any day. But of course the alternatives could include finger prick or heel prick, DBS, and point of care viral load testing. So in summary, I would say that for MSF, treatment as prevention is an explicit priority in high coverage contexts. We think of treatment as prevention as focusing on quality and cascade optimization, meaning increasing HTC linkage, in adherence and retention, but then of course earlier access to ART and with resistance surveillance accompanying that. And our approach in these contexts, as I said, is to focus on implementation research. We think this is where organizations like MSF can complement larger ongoing studies in order to show us how to integrate treatment as prevention into HIV programming. Thank you very much. I just want to thank the contributors to this presentation, as well as our partners in the Ministry of Health, and I think there will be a presentation from the head of the National ART Program in Swaziland tomorrow. Thank you very much.